Hello, and thank you so much for joining us today for the webinar Indication for the Third Dimension, CBCT's range of applications beyond implantology. It is a great pleasure to introduce to you Dr. Heinz Theo Luebbers, whose aim during this presentation will be to discuss how to use the additional information gained through 3D radiographs for diagnosis and indication of treatment. We'd like to thank Dr. Luebbers for being with us today and DT Study Club for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Luebbers at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Heinz Theo Luebbers.
Dear colleagues, it's a pleasure to have you here, and it's an honor for me to be able to give this webinar. And we are talking about, or I will talk about, indications for 3D imaging. And I don't want to focus on implantology exactly, but on all the indications we might find besides implantology. So just some words to make me popular, or that you get to know me. I studied medicine and dentistry in Hanover in Germany, and I specialized in maxillofacial surgery in Zurich until 2007, and then I spent 8 years at the University Hospital in Zurich as a consultant, and later on, since 2014, end of 2014, I'm working in private practice in Winterthur, Switzerland. I'm a board member of the Swiss Association of Dentomaxillofacial Radiology, and of course I'm linked to cone beam CT in some way, except for the daily business in a scientific way. So let me make one first general remark about the image quality you are going to see during this presentation. It's not always what we would call the best image quality by the matter of the most perfect image you can get out of machine, or the most nice image you can get out of a machine. But I'd always try to refer to a principle that's called ALADA. It's many of you might know the ALARA principle, and ALARA principle was introduced in 2000, and it means as low as diagnostically acceptable. So basically the idea is to reduce the image quality in order to reduce the radiation dose applied to the patient down to a level that is diagnostically still acceptable, but the result might be an image that is not very nice to look at. You can see everything on the image, and you might think, well, this could have been a better image, but it's an image like it is because we reduce the radiation dose as much as acceptable. So what are today's indications for 3D imaging? Of course, everybody is discussing wisdom tooth or wisdom teeth. With you see an OPT here where the nerve is running over the root. This would be, for many colleagues today, a clear indication for 3D imaging. Of course, dentists, I promised, of course, implants. I promised not to talk about implantology too much, so this will be the only slide about implantology. And then there are several bone situations like this Staphne cyst or Staphne cavity you see below with the lingual opening, a nice indication for cone beam if you want to find this lingual opening to make sure you're the right diagnosis. And of course you can do all kinds of fancy stuff like in these pictures where we made a fusion of two data sets to ensure that this cavity here is definitely static like it should be. So the content of the presentation is some basics about radiology and cone beam CT and some basic principles. Then wisdom teeth, cystic lesions and other bone pathologies. I will have a trauma case, just a little one, to show where the trauma indications are. And I will talk a little bit about periapical lesions and wood amputation. And finally, of course, some conclusions to all this content. So we start with the basics. And there's one basic problem in conventional radiology, and this problem is the 2D result you always get. So if you think about this picture, you you actually see this as a result of your 2D radiograph. And what you want to see, or what you want to analyze, is this object here. So now imagine for you, you kind of know this rabbit since you studied anatomy, and there might be a little chance you get a correct impression about this rabbit by this picture. But now think you're a patient. You don't even know this rabbit any at all. You never studied anatomy, so you don't know what a rabbit looks like. And still, you should be able to make yourself a picture of a rabbit out of this. And that's almost impossible. That's why I like 3D imaging a lot, especially for patient education and for informed consent. The beginning of 3D imaging was in 1971, I would say, with Cormack and Hounsfield. It was very interesting because they were no team actually. They won the Nobel Prize pretty fast. And one big issue for the success of 3D imaging probably was that there was no patent on it. And this picture here you see is probably the first medical computer tomography. It's a patient with a brain abscess. And look at this picture. This is not a tooth with an external resorption or something. This is a whole head. The quality is really low, and you can see the brain abscess right there. But it was actually the first time you could look into the brain and into the head and have a good image of structures like this abscess. So some other basics. Pain, let's take a patient with pain. Pain is subjective, and a patient is in pain. That's the definition whenever he says he is in pain. Pain does not show an X-ray. Like a lot of clinical symptoms, we actually don't see the pain in the X-ray, of course. What we are looking for is some pathology that correlates with the pain. So a pathology we know that this correlates with the pain the patient has. And after then, of course, we can have a diagnosis, and then finally, after the diagnosis, we can treat the patient. That's the final goal. And this slide implies what we want to treat is not what we see on the X-ray. Of course, there is a correlation, or at least we hope that, but we don't treat the X-ray. That's an important point. We come to that later. When you talk about CBCT nowadays, you have to deal with missing evidence. One problem is that for many, many indications in the dental world, we are lacking sufficient evidence regarding the simple question, is 3D imaging helping the patient in his situation, or is it helping us to help the patient, or is it not? And there's one general agreement about missing evidence. Whenever it comes to missing evidence in the literature, the best you can do is to use common sense combined with expert knowledge. So this is where we are standing right now, I would say, for many indications in CBCT, and also for many other indications in medical CT and so on. And for many indications, it might also be difficult to achieve sufficient and convincing evidence. There are ethical matters regarding control groups. So if something is quite obvious, it's always difficult to build a control group against it. I'll show that on some other slide. There are difficulties in estimating the health effects of X-rays. It's not as simple as one might think. And there's an ongoing technical development. So whenever you find evidence for something is working or not working, there will be a next or the one after the next generation already in CBCT machines with better pictures, with low radiation doses we can see right now. So you're always running behind the scene. The wish we all would have, or we all have, is something as clear as this study. It's a study which is looking at whole body CT during trauma resuscitation on survival. So we have a patient with a trauma. There are 4,500 in this study who had a severe polytrauma. And they found out that whole body CT reduces the mortality, and you need 17 to 32 patients to achieve one more survivor compared to a non-whole body CT. Whole body CT means you always make a medical CT of the whole body of the patient, no matter of the clinical signs, compared to the other strategy to apply a CT only to those areas of the body where you have clinical signs of injury, for example. So if you say I do a whole body CT on a polytrauma patient all the time, after 17 in the best and 32 patients in the worst case, I saved a life. That's pretty good evidence. You still can discuss on it, but it's pretty good evidence for the situation in this trauma patients. I'm pretty sure we will never get that clear evidence for our dental situations. But you mustn't overrate evidence. So there's one study which tried to find out if parachutes actually prevent death or major trauma if you jump out of a plane or if you fall from great height. And they made a systematic review of all randomized controlled trials, and actually they find out that this effectiveness of the tool of a parachute has never been proved with a correct trial. Of course, I don't want to question parachutes, but I want to make clear that hard evidence is not everything. Sometimes things are that obvious that it might be foolish to go for scientific evidence for that. So what I can present today is kind of my view. I can, of course, give you an overview what the consensus statements of the different countries say, but basically it's after all a subjective view of myself what indications for cone beam CT are useful and which are not. Radiological diagnostics start with dental films. That's normally the first step. And then if we don't get enough information out of that, we usually go to panoramic. And then there's, for me, there's like two ways. If panoramic doesn't help, you can either wait and retry sometime later when the problem might have grown bigger, or often it has gone away also. Or you can choose a way to look further into it, and you do a cone beam CT, MRI, medical CT, ultrasonics, all these options you have nowadays. And at every point of this chart, you can like turn around and say, well, time is also an option. We can look for this fourth dimension and look again later, depending on the patient situation, of course, depending on his clinical problems. But in very many cases, with like typical radiological signs but no clinical signs, this is a useful option, I would say. Let's go for wisdom teeth. Well, how is the situation in wisdom teeth with cone beam CT? We published a paper about unclear facial pain, and this is a typical picture from this publication where there's a retained wisdom tooth, and this patient had an unclear pain on the right cheek. And we did a CT scan at that time, and we easily found the problem. And if you look at this axial slide here, you can see the tooth which is in here. It's the same. You can see the lesion here. You can see the periapical lesion. You can see the beginning abscess formation here. So it's a pretty clear indication how you might want to treat this patient. Removal of the wisdom tooth, and the problems are gone. Another case where maybe cone beam CT wasn't really necessary, but it anyway solved the problem. This is a persistent pain after removal of a lower third molar. It wasn't adequate, the pain, so we had a look into it by cone beam CT of the area, and what we found was this. So we actually found the lesion on the last molar here. Pain had nothing to do with the wisdom tooth removal, just a coincidence in this case. Sometimes even things are just a coincidence. And the treatment was easy then, of course. Probably you could have found it without cone beam CT, however, we found it with cone beam CT in this case. So why is cone beam CT for wisdom tooth a topic? The anatomy of the inferior alveolar nerve in relation to lower third molars is not very constant, let's say, or it's, in other words, it's constant that it's totally inconsistent. You usually find the nerve on the vestibular side or vestibular apical, but that's only like 52% of the situations. And it's all wisdom tooth that in the panoramic view have an overlap between the nerve and the roots. I think it's about 800 or something tooth in here. But 37%, almost half of it on the lingual side. Excuse me. And even 10% are between the roots. Oh my dear. Or even through a root. That's quite a high rate of this critical situation. If you look into it, what's the risk factor? So what's a critical situation for a nerve injury after wisdom tooth removal? You can see that there are actually only two independent factors right on this right side here. Number one, which raises the risk by 3.6 around or 3.7, is a narrowing. So if the mandibular canal narrows close to the root. And the second independent factor is direct contact between the nerve and the root. All other factors about the position and fully developed root are somehow dependent on this factor, so they are not independent in correct analysis. If you compare 2D to 3D, you can see that there are 2D factors like narrowing of the root, diversion of the IN canal. You all know them. And in 3D, there are not independent factors in this case. Lingual, through the root, in between the root. Direct contact between nerve and root. And the reduced canal diameter, we heard that before. What has to be said is that it has not been proven that cone beam CT actually reduces the risk of nerve injury. That's well, you can't really say it's open because there are some studies that show that it's not the case, but still it looks a little bit like the parachute issue to me. This is a situation, and this is very interesting case from this, because on this side, on the right side, I would have said, well, that's a cone beam indication, you know. The roots are completely overlapping the nerve canal, even going like 1 or 2 millimeters below. And then you look at the cone beam data, and you see that the nerve is on the outside. It's right here. It has right there at the tip of the arrow. It has a separation, a cortical separation from the roots, and the diameter is not reduced, or at least not really reduced. So actually, one would say this side is not a especially high risk side. The other side, I would not have done a cone beam in most cases, probably, because I'd say, well, there's an overlap, but it's not complete. There's a part of the nerve canal that is not overlapped by the roots. And then you look in there, excuse me again, and you see your big surprise. Actually, the nerve situation is much more critical than on the other side. The nerve is quite compressed. It's on the lingual side. There's a direct contact from the nerve to the roots. So actually, this tooth on this side is much more critical to remove than the one on the right side. This is a classical example for what good of impression we get of the situation in cone beam CT and how actually bad our judgment could be on panoramic. And again, there's no clear or there's no evidence to say that I get this root out safer due to having this cone beam data. But again, for me, it's a little bit obvious, I would say. Another question is this tooth. So what would you do with it? It's got a nerve right here, close to the root, compressed, really pressed into the lingual cortical plate. And what do you do with it? Leave it alone would be an option, actually, if you see the situation. But then if you have a closer look here, you see this, and this won't go away by leaving the tooth alone. So actually, get data about the nerve and the grist situation, and you say, well, maybe we leave it alone. And then you say this and see this and say, well, maybe we'd better take it out because this problem is going to grow and make pain. And you remember the case we saw before. Finally, there's probably going to be an abscess formation. This is another case of not really wisdom tooth, but it's related to wisdom tooth removal. The patient had a problem not in this area that was clinically clear, but in this area there was a feeling of pressure and sometimes pain, and there was liquid coming out. And this was several years after wisdom tooth removal. The OPT for me is suggesting that there's something around. If you compare with this picture, the bone formation that should be here, like here, you see the region here, the bone is gone. If you look at it magnified, you might think there's something here or maybe here. And if you then look at the cone beam, you very clearly see that there's a foreign body, probably root. I mean, the statistics say it's root, and it's clearly a infectious formation there. Maybe a cyst, maybe just infectious tissue. But now you found a correlation, which we talked about before. You found a correlation to the pain the patient has, and then finally you can treat it. Cystic lesions. I want to show some bone pathologies like this Staphne bone cavity, Staphne cyst, which normally is a pretty clear shot already at the OPT. I mean, this is more or less a clear situation, unless you have something like this, which might not be typically for a Staphne. Normally it's below the nerve, the nerve canal. And then, of course, in the cone beam, you can easily see the lingual opening of the situation. And this slide also shows what you should not do. You should not refer to the 3D that is reconstructed by the software, because this 3D surface rendering, which it's called correctly, it's always cheating, kind of. It's trying to make you and to give you a smooth surface, but to achieve that, it's gonna produce either holes like here, where there actually is no hole. The vestibular, the outer cortical plate is thin but intact, or it creates you like a closed surface, for example, in a non-dislocated fracture, where there actually is a small gap, but the algorithm is just calculating it away. What you can do, we saw that before, is to overlay this bone cyst. If you have any suspicion that there might be a change in the Staphne cyst, you can 3D fusion the data sets, and then you can see that actually this area here didn't move at all. And this red and blue areas here are just a result of movement of the patient. So the registration of the 3D data was made at the mandible, of course, and then the vertebra was not in the exact same spot. Same here with the upper jaw. The upper incisors are not in the exact same spot, because on the blue picture here the mouth was closed, on the orange one it was a little bit open. And I would expect something like that in this cyst area too, if there was any type of change in the cyst. Another point, idiopathic osteosclerosis, you see it right here. It's a situation where dense bone forms right inside the normal spongious bone. We don't really know where it comes from, but we know it's not relevant. And you might want to rule out that it's something else, like it could be a stone from a gland, for example. So if you want to make sure that this structure is really inside the bone, there's actually no better way nowadays than do a cone beam CT, and then you actually see it right there. And you can even make sure, well, this is on this picture already sure, but you can make sure whether it's connected to some tooth or not. It's quite widely accepted that in cases of bigger surgery for osteonecrosis of the mandible, you want 3D imaging. Normally in 2D imaging, the amount of osteonecrosis and the severeness of the situation is always underrated. So you always see more problems and more sequestrum and more dead bone in the 3D imaging. That's pretty much a constant situation. So prior to surgery or to evaluate even this class 0 levels of OJN or ONJ, you need 3D imaging also. Trauma, I only want to show one little case of trauma. So we are pretty much clear with trauma. There are two areas where you actually rely on 3D imaging. One is showed here. One is shown here. It's a condylar fracture, a sagittal fracture of the condylar head. You almost won't be able to see them in a classical panoramic view. The fracture line goes from posterior to anterior, right through the condyle here. Normally, the medial part of the condyle dislocates downwards through the muscle tension, and the lateral part is in position. And the lateral part also keeps the function and the position of the mandible and everything correct. So of course there is an initial disturbance for the patient through the pain and the swelling and everything, but there's almost in all cases there's no long-term problem. The second part for the trauma, I didn't show a picture here because it's even less related to general dentistry, would be orbital traumas. The orbit is a structure which you can hardly judge on conventional X-rays. You might be able to see a fracture. You're almost never able to rule it out for sure. And once you see one, you definitely want 3D imaging to judge whether you need surgery or to pre-plan your surgery. So after all, in a fracture of the orbit or a suspicious situation for a fracture of the orbit, you would want a 3D image. That can be a medical CT, of course, because in head trauma, you sometimes suspect bleeding and other problems. But if you don't suspect other problems, you can also use a cone beam CT and spare the radiation dose, let's say. Periapical lesions are always a topic, and I tend to say they are underjudged in 2D imaging too. If you see this tooth, typical periapical lesion, and then you finally see the situation on the cone beam, then you clearly see that there's quite a huge periapical lesion. And for planning the surgery and being sure you don't open the maxillary sinus and everything, it might, depending on the situation, of course, what you want for the patient. For an extraction, you won't need that. But if you want to do apical surgery here, or if you want to do an endo treatment again, you might really discuss 3D imaging for these cases. Another case which is classic for 2D images of periapical lesions. This tooth here definitely has a periapical lesion, as you can see here. It's the root right here. It's another sagittal view of the same situation, and you can clearly see the periapical lesion, which you can suppose that there is one here, but you cannot be sure, and you're definitely not sure about the extent and whether the second root is affected or not, and all that details you might need to know. By the way, this fractured instrument by itself here would, by clinical rules or by guidelines, be an indication for root resection. Very interesting case would be this one. This is actually three images at different points in time, so I think it's over a year or maybe two. And we were asking ourselves, what this lesion here might be. And we were thinking about an early form of infectious sclerosis there, which might explain why the structure is changing, and then periapical lesion here. And finally we did a cone beam, and then we saw this. It's as simple as some sealer that is here in a periapical lesion, and I really wonder how this changes here could happen, because it's always the same tooth, the same situation, the same image. But it's, in my belief, it's just due to some angle issues with the dental film, because I won't believe that a sealer in the bone here would change its structure from this to this to this. That doesn't seem logic to me. So what we know about periapical lesions is that the histology as a reference with 100% sensitivity and specificity and accuracy finally. The panoramic has only 25% sensitivity rate, and well, whenever you see one on a panoramic, it's really one, so you get 50% accuracy. The dental film has 70%, and the cone beam CT has about 90% of the periapical lesions you are able to pick up. So what can we make from that out of the guidelines? Cone beam CT for periapical lesions is indicated whenever you have a clinical sign for a periapical lesion, but you don't have any pathological findings in conventional radiography. And mostly you won't go for surgery or for some treatment if you don't clearly see what you want to treat. If you have anatomically complex lesions, especially in upper molars, of course, and if you have a close relationship to the maxillary sinus, which would more or less be the same, upper molars or molars in general are also recommended. And I would add, from my personal view, I would add if a maximum of diagnostic sensitivity is required, let's say for patients who are going to undergo radiation therapy of the region, for example. I really want to find any periapical lesions that might be activated by them, by the radiation therapy. And obviously radiation dose is not an issue if the patient is going to have radiotherapy after. So there are some good indications for periapical lesions, not for all of them, of course, and always depending on what your treatment goal might be. Prior to root amputation, there are different indications, like a situation like this. If it's really complicated to sort out which root is a problem and which root has to be resected or amputated and which not, it's always good to get a good view inside before you do surgery, and not only for surgery but also for informed consent of the patient. Let's already get to the conclusions. I have more than one slide of conclusions, obviously. We have a data set of isotropic voxels. If we have a cone beam CT, we always get a data set out of voxels. A voxel would be like a 3D pixel, and isotropic means they are all of the all edges have the same length, and this makes it possible to cut planes. You can have an axial plane, you can have a sagittal plane or a coronal plane, and all planes show the same quality of the image. And as more planes we get, as more information we get. It's also obvious. I mean, if you only have this view, then you really miss the unique selling proposition of this tower. And if you have this view, then it's pretty clear why so many people are going to have a look at this tower there. So one question is, which plane do I have to utilize? And there's a very simple answer to the question, which plane is the best one to see something. The answer is there's no plane that is the best one. You need the volume. You really always need the whole dataset volume, and to move around. Of course you use planes because otherwise you cannot see anything. As we said, 3D rendering is not worth to have a look at if it comes to diagnosis. But you need to have the freedom to use every plane you just might want and need for that special situation. No such thing as a best plane. So what are the keys for radiological diagnostics? First of all, systematically review the picture. I mean, that's should be normal for panoramic, of course, but on panoramic you can pick up a lot of things by just looking at them. If you just look at a cone beam CT, you might miss a whole bunch of things. You have to go through the whole volume from up to down in all three main planes at least, and depending on the things you see, you might even want some extra planes. If you have any doubts, show it to colleagues, show it to a study club. It's very important to get some other insight into the situation, and it helps very often. And for cone beam CT and MRI, I would recommend to let them be made and diagnosed by some specialist, by some guy who sees a lot of those pictures, because otherwise it's very difficult really to pick up all the information you could pick up in these images. And the last point, of course, is continuous education. So if you decide to use cone beam CT or to run one by yourself, go for some kind of continuous education, whatever type you like. One very big issue I like a lot is what was published in 2003 in the British Medical Journal, and it's called VOMIT, the victim of modern imaging technology. Hayward introduced this acronym because he saw that there are a lot of situations where we see something in modern imaging technology, just like cone beam nowadays, and we don't know what it is, and then we start treating it. Regardlessly, we don't actually know what it is and what it means. So what he said is modern imaging technology, or modern imaging, produces red herrings. Red herrings is you might know it from your most popular crimi or something. It's actually a distractor. It's like the gardener who's finally not the murderer, but always seems to be the murderer. This red herring leads the physician or the dentist to be really uncertain. It leaves the patient to be uncertain, and it brings you not even one step closer towards the solution. Maybe you get even steps away from the solution. And it's not really a bad thing. I mean, it's bad they're there, but there's no chance you can avoid it. It's just natural. The capability of interpreting some findings only can come after you are technically capable of revealing the finding. I mean, you cannot learn to interpret something you cannot see. So you will always have the situation that with modern imaging you see something and you don't know what it is. That's just the price you pay. In daily practice, the patient has a complaint, often it's pain, as I said before. We search for some clinical correlate, and we search for some radiological correlate, dental film, panoramic X-ray, cone beam computer tomography, whatever, MRI, medical CT. And finally, we do the treatment. Another area I didn't talk before now is informed consent. I think in the context of informed consent, I mentioned it shortly with the rabbit picture, if you remember. 3D imaging is indicated when the patient's decision might be influenced by the additional information. So if the patient can really get a good insight into the situation through 3D imaging, this sometimes might change his mind about which treatment is the right one for him. So a patient might decide against removal of lower third molars if you can show him that there are special risk signs. That's an indication you have to take into account. And very simple from a surgeon's point of view, as I am a surgeon mainly, preoperatively, I just want to have the opportunity to do a 3D imaging if I believe it's necessary for performing the surgeon to require for some technical reasons. So if I, as a performing surgeon, believe I need 3D imaging, I want to be able to get 3D imaging. There should be no guideline in my way, let's put it this way. And the topic of forensic obligation, to date there is no obligation to perform CBCT in any indication, but I'm pretty sure this can change. Of course, anytime if there's a prevailing case law or new clinical evidence for some situation, but that's normal. I mean, in medical area and in dentistry, you have to keep your eyes open and see if some treatment comes up which is the new golden standard, and then you want to change your old mind, moving to the new treatment concept. So what are the indications? Let's put it together for cone MCT. We can analyze risk factors prior to removal of lower third molars. It's not proven, or there's no proven impact on outcomes. Some studies show that there's no impact, but it's always difficult to show the absence of something. So we might never see really clear there, but we can get a lot of information out of it for informed consent, for technical aspects of the surgery. Cystic lesions, if there's close relationship to some structures like the nerve or other tooth or something, always an issue. If the cystic lesion becomes of a certain size. Any questions related to some complex skeletal regions like the orbit, the TMJ, I showed before. If you need imaging of the TMJ, you can either choose MRI and you get your soft tissue images very well, or you can use 3D imaging. Actually, all types of 2D imaging, conventional X-ray, Panorex, you name it, for the TMJ, they don't give you good results. And if you need a high sensitivity for periapical lesions, we talked about that before, especially upper molars, especially situations before radiotherapy, maybe situations before chemotherapy or bisphosphonates, you might want to have a cone MCT. As I said, preoperatively, if required by the performing surgeon, it's a very simple rule for me. And what we result in, and what I like a lot, is there are no more surprises. If you take out a wisdom tooth, like in this case here, and there's a nerve right in between the four roots after all, that's not mainly a problem, but it's no surprise anymore. So you know beforehand, you can talk to the patient about it, it's going to result as you want, and there's not a surprise in any way during surgery. And I personally don't like surprises during surgery. Surgery is how should I phrase it? It's a professional procedure which should work out from the beginning to the end just the way you planned. No room for surprises of any type. This is a picture to that, very clear. Of course, there are always special points like the root fragment. I like that a lot. Again, a topic of no surprise. I mean, if you are looking for the root fragment, you want to know where to look. And in this case, you don't look inside the bone, but you look on the lingual side of the bone. It's in a way easier, in a way more difficult. That's not the issue here, but you know where to look, and that's important if you want to find it fast. Question for the future. Will we always utilize CBCT? So is panoramic view going to become completely dispensable? You can think about it. I can think about it. Big problem is it's difficult to make predictions, especially about the future. This has been said by many people before, and it's actually a fact. We don't know. Right now we see that with modern machines, like the one I luckily can use, you can push down your radiation dose down to a level that's about the level of the panoramic view, but it's still more expensive. It's still a more expensive machine, so you don't know where it's going to. mostly with most machines nowadays, the Alara principle is still in the way, you know, like we always say the radiation dose should be as low as reasonable achievable. So in most cases nowadays, panoramic X-rays have a lower radiation dose than CBCTs has. But I'm personally pretty sure from what I see in the technical development right now that this at least is going to change. The radiation dose of CBCT is already partly going below panoramic X-ray, and it's probably in the future going even lower. You see some data here. If you have an effective dose for a dental film, it's like 2 microsievert and maybe up to 4. And the CBCT of the maxilla, if you go really for this ALADA principle I showed before with a low dose mode, you can be in the level of a dental film or a bite wing film. And then the panoramic view ranges from 14 to 24. And depending on the region, you are right in there with your CBCT. So if you focus on some region and you use a low dose mode, you can, with a CBCT, end up with a lower radiation dose than with your panoramic view. And so, for example, here two results of the same effective dose. That's a classical panoramic, of course, and that's a 3D image which with a really low dose mode. And that's actually the same radiation dose, more or less. And now you can tell me where you get the better information out. Of course, it's not the theoretically best 3D image, but it's still, I can see a lot more than on the panoramic view. And finally, the best way to predict your future is to create it. So I hope they will go on, create great CBCT machines and reduce the radiation dose. So if your final result in radiation dose is lower than a panoramic view, I would say then a lot of indication discussions then are solved, because if the radiation dose is no issue anymore, I'd say go for this CBCT. That would be my final slide. I'm happy to answer some of your questions. I see there are already some questions that came up, and I think the idea is that I go through the questions now. First question is what about indications in endodontics? Actually, I'm the wrong person to ask that. I'm a maxillofacial surgeon, so I'm quite away from endodontics. I know that there are some endodontists that do perform CBCT, I think more or less for the same reasons I perform it when I go for root amputation, like complex anatomy, check out where there's an instrument maybe in the root canal, but it's definitely not a routine indication for endodontics. The second question was, can the osteosclerosis be differentiated from zeoliths by using SLOB technique or Clark's rule? I think this refers to conventional X-rays in different angles. Of course, you can differentiate it. You can even differentiate it if you're used to it by having a close look at it, because the zeolith will always be less sharp than osteosclerosis. Idiopathic osteosclerosis is right in your focus line. It's inside the bone, so it's going to be sharp. And zeolith is not going to be sharp because it's outside your focus level. You can clinically look at the patient, and of course you can use different angles for X-rays, even though this knowledge, I would say, slightly goes away. Nowadays, students, they don't really know anymore how to apply this how to apply these techniques to conventional X-ray. And in bigger clinical settings, it's always a problem to clearly communicate the information how you want your next X-ray to the X-ray station. You get the same X-ray again. That's a problem unless you do it yourself. But of course, the easiest way or safe way to differentiate will be just another view. What is the approximate cost of a CBCT setup? Is a third question. That's difficult for me to answer because it's depending on so many questions. What company do you choose? What's your field of view? What you want for a cone CT? Probably which country you live in. That's not so simple to answer, but it's easy to find out. Just call your dealer and he's gonna tell you. Any books to refer for CBCT? I actually no, I won't refer to a book. I mean, there are a number of books, but the key issue to getting to know CBCT is to interact with the data. So if you look at a book, you get the same you get from my presentation here. Actually, you get some nice pictures where everything is pretty clear, especially if somebody explains it or writes a sentence next to the picture. But you don't learn to use it. What you need to do is you better go to a course or meet in a study club and then have a close look at CBCTs. And it's like with computers. It's learning by doing. You don't learn to use PowerPoint by reading a book about PowerPoint. Theoretically you can, but practically, at least for me, it's not working. Next question. Can cracks on the tooth root be recognized with 3D? Thank you. Yeah, thank you for the question. They generally can, but you can't rule them out. If you have a crack and you have some degree of dislocation, you will see the crack in the root. However, if the dislocation is minimal, you cannot rule out a crack in your cone beam CT. That's a big problem because you want to rule it out. Normally, you want to rule out that there's a crack. And the next point is very often roots with cracks are filled. Once you get a root filling, you get problems with your cone beam CT and with artifacts. Very good question. Also the next one, how to differentiate by condensing osteitis and osteosclerosis? Well, it's not really possible. It's not really an issue also. For condensing osteitis, as far as I know, there has to be a vital tooth next to the situation. So there has to be a filled tooth or one tooth that is reacting negative on our not so reliable cold test. And idiopathic osteosclerosis is away from the tooth like the one you saw or at a vital tooth. But after all, in both cases, you more or less do nothing, so it doesn't really matter which one is it. And the question about is the radiation dose in CBCT less compared to panoramic? That's a no but. In most cases, the radiation dose in CBCT is higher than in panoramic view. But under special circumstances, let's say you go for a special low dose mode, that is like it's implemented in some cone beams nowadays, for example in the one I use, then you can get to radiation doses compared to panoramic or even lower than panoramic. And if you, as a next step, also reduce the field of view, let's say if you only look for an implant situation, or if you only look for two wisdom tooth on the right side to be taken out, then you focus on this one wisdom tooth, then you definitely come out with a lower radiation dose for this X-ray than if compared to a panoramic. But again, you can do a half panoramic, for example, and reduce it on that side. But you always have to take into account what is the resolution you use and what is the field of view, what type of machine. So you can't really say it's that simple, but probably in 10 years the answer to this last question would be a yes. But as we said before about prognosis in the future, I don't know. No more questions on my list.
Thank you very much, Dr. Luebbers, for sharing your lecture and your insightful information with us. We'd also like to thank DT Study Club for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You receive an email notification with a link to the recording. Further questions for Dr. Luebbers may be submitted directly on the website, on the courses page, under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Luebbers will be sure to get back to you as soon as possible. Please be sure to visit the DT Study Club educational platform, www.dtstudyclub.com, and keep an eye out for a growing schedule of online courses. Thank you again to all, take care, and goodbye.